And today's recording will be posted on the committee's webpage shortly after the meeting. And Pam McEwen, FTAC Liaison to the Universal Healthcare Commission, will now call the meeting to order.
Welcome, everyone. It's now 2:01 p.m. and I'd like to call FTAC's July 13th meeting to order. We'll begin with a land acknowledgement today. I'm joining you from Winthrop, Washington, and so I want to acknowledge that I'm speaking from the traditional land of the Methow and Colville Confederate tribes, past and present, and we honor with gratitude the land itself and the people who have stewarded it through the generations. I'd like to give a warm welcome to everyone who's joining us today for our fourth FTAC meeting. I'll start with an overview of the agenda. Has that been shown yet? Sometimes I get a little bit of a lag. We're going to start with roll call, and we're going to use this opportunity to urge the commission members to continue to get to know each other a little better. So when your name is called, will you also let us know your favorite thing to do in the summer? Next, we'll vote to approve the May meeting summary, and that's going to be followed by public comments. Then our consultants, HMA, will share where we are in the work plan and updates from the Commission's June meeting. We're going to have two presentations on ERISA today. First, we'll hear from Carmel Shashar. I'm going to have to ask her to help me pronounce her name, on a brief history of ERISA and healthcare policy. Then we're going to hear from our own Commission member, Jane Beyer, on ERISA issues in Washington. Finally, HMA will come back to share next steps. As always, I encourage FTAC members to ask questions and provide feedback to help facilitate today's discussion. I'm going to turn us back over to Angela, who will take us through the roll call.
Thank you, Pam. And please remember when your name is called to let us know what your favorite thing to do is in the summer. And first, we'll start with Pam.
So thanks, Angela. My favorite thing to do in the summer is to swim outdoors. Any body of water, which I can stand the temperature.
Do you need a wetsuit for that, Pam, or are you brave?
I try to be brave, but I tend to favor lakes over the sound.
That makes sense.
Yes.
Excellent. Christine Eibner?
I'm here, and my favorite thing to do in the summer is to go to outdoor concert series and other sort of outdoor activities.
Oh, nice. David DiGiuseppe?
Hi, everybody. I'm here. My favorite thing to do is go backpacking. I just got back yesterday from a nice trip to Echo Lake in the North Peak Wilderness.
Where did you say Echo Lake was, David?
It's in this area called the North Peak Wilderness.
Oh, how far is that from here? Well, from Seattle.
No, it's only, the trailhead's only 2 hours from Seattle.
Oh, not bad. That's a nice.
Yeah, near Enumclaw.
Nice. Thanks, David. Eddie Rouser?
Present. I hope to have a new favorite thing to do, and I think I'm pretty close to Roger, so I'll be spending some time at Swantown doing some sailing.
Oh, wonderful.
Oh,
Wonderful.
Yeah.
Very cool. Esther Lucero? Esther? Ian Doyle?
Here, and my favorite thing to do is to play golf during the summer.
Oh, very nice. Kai Young. Kai? And Robert Murray? And Bob did let us know that he won't be attending this afternoon. Roger Gantz.
Good afternoon. Once you say our favorite thing to do is actually during the summer is attend FTAC meetings, but that might be a bigger thing. I think mine are twofold. One is bike riding, and the other is still going to art galleries.
Oh, nice. Nice that those are opened up again after the pandemic.
Yes.
Okay, excellent. Thanks, everyone. I will turn it back over to Pam.
Okay, please join me in turning to the second tab in your materials. And the recording of the last meeting is posted on our webpage. We use the consensus process to vote on the approval of the May meeting summary. So first I want to ask, is there any discussion of the meeting summary or any proposed changes from anyone?
Yes.
Okay, is that Roger?
Yeah, yes. Thank you. I have a sort of a, I want to say it, maybe a clarifying addition if possible, and it pertains to page 4, and it's regarding our discussions on the Medicare options. And I'm looking at the motion number 6, And while the language in there is correct, I'm a little concerned that it may be somewhat misleading it to the commission insofar as option 6 is not dependent or necessarily related to option 1 or 2. Option 1 was, we talked about, was essentially around the notion of either seeking legislation or a major waiver to bring Medicare in. And we talked about those options aren't currently available without congressional action. And option 2 dealt with Medicare options that are available, which in our discussions focused primarily at those that are available now through payment options through the Affordable Care Act. And the option 6 ones are options that are available through existing waivers or other structures, particularly with the Medicaid program, that aren't dependent upon option 1 or 2. So I think what I was trying to share is they're not in and of themselves connected.
I think that could be a simple addition, which is just to actually just use your words that these two are not necessarily in and of themselves connected.
Yes.
With that, would that address what you're concerned about?
Yes, because I think again, yes, it would, and I guess the point being back to the commission as they think about Medicaid or Medicare, options. Again, that this one is available without having to go through the major reform effort, should they want to continue to give it due consideration, which they've indicated that they do.
Okay. With that addition from Roger, are people able to approve the amendments? The minutes. Okay, all those in favor, please say aye.
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 Any opposed? We're approved by consensus. And Roger, thank you for bringing that up, making that change. Next, we're going to move on to public comment. And committee members can find written public comments under tab 3. We allow individuals to sign up to provide public comment before the meeting, and we will start with those that have signed up to provide comments. When you're called upon, please state your name and affiliation, if any, before speaking. We will be displaying a timer to remind you of the 90-second time limit. When the timer stops, please stop your public comment. Angela, would you please start with the names of the individuals who have signed up to provide us comments?
First, we have Roger Collier, followed by Warren George. Roger, if you'd like to come on.
Okay, am I visible and audible?
Audible only.
Okay, well, you probably don't need to see me anyway. Okay, so thank you. And I particularly like being promoted. So I'm very pleased that Professor Shacker, I hope I'm pronouncing the professor's name somewhat appropriately, is available to provide her ERISA expertise. And I'd be particularly pleased if Professor Shacker would comment on a couple of my comments, which are in the public comment documentation. So first, it looks like the payroll tax proposals in SB 5335 and also in Oregon's task force plan could double health benefit costs for at least some employers, not all of them by any means. On the average, it's pretty much of a wash, but clearly employers who are paying less today are going to be paying a lot more in the future with approaching a 10% payroll tax. So the question for Professor Shaka is, what then are the implications of the comment in the Travelers versus, New York Blues Supreme Court decision that an exorbitant tax might be treated as a substantive mandate in violation of ERISA? Obviously, the issue is doubling somebody's benefit costs exorbitant? Okay, second question for Professor Shankar. Based on other ERISA cases, seems to me the federal court process to resolve the preemption issue could take as long as 4 years, and that's after single payer legislation is enacted at the state level, which in turn might be after state court proceedings also. So, summarizing the question for Professor Shaka, am I close? Thank you.
Thank you, Roger. Next, we'll hear from Warren George, followed by Chris Curry. Warren, if you'd like to come on.
Thank you. Warren George, I was a member of the Oregon Task Force on Universal Healthcare. Want to continue encouraging the idea of regional cooperation between Oregon and Washington. And as I have testified before, I really believe in the benefits of single payer as opposed to public options. And I hope you will not be adverse to receiving flowcharts and other information based on Oregon data that will encourage both coordination and looking at single payer as Oregon has. Thank you very much.
Thank you, Warren. Next, we'll hear from Chris Curry, followed by Marcia Stedman. Chris Curry, please. Chris, are you having any trouble coming on? I see you trying to come off mute, Chris. Chris, are you able to come on?
Yes, I think I'm on now.
Yep, we've got you.
Yeah, I'm Chris Curry, retired RN from Spokane. And I would just like to remind the FTAC that ERISA is really only an issue within the context of a single payer universal healthcare system. Since self-funded employer plans need to be, quote, regulated by the single payer if that system is to be financially viable. So I hope the Commission's interest in having you discuss the potential ERISA roadblocks this early in their process means that they are truly committed to a single payer concept. So perhaps you can include this point in your report back to the Commission as a means of seeking clarification regarding the Commission's ultimate goal. For an additional summary of how ERISA can be handled in the single payer context, please see my report included in the May 23 FTAC meeting materials. Thanks.
Thank you, Chris. And then finally, for our signups, we have Marcia Stedman.
Hello, hi everyone. I'm Marcia Stedman, a volunteer with Healthcare for All Washington. And first of all, I have some good news. Washington's 2023-25 biennial budget includes increased funding for the FTAC and directs that it be used for the actuarial consultants you will need as you consider and recommend a financing system, including a single payer system as specified in the law that created the Universal Healthcare Commission. So we are expecting to see a revised work plan very soon with more robust agendas and meeting schedules. Meanwhile, you can save time on ERISA by following the Oregon Task Force's example on it, included in today's meeting materials, pages 68 through 74. And finally, there are two existing universal healthcare models that show how Washington could structure an ERISA-proof universal healthcare system. Mr. Collier has already referenced one of those, the Washington Health Trust, which will be heard on the August 10th Universal Healthcare Commission meeting. This is based on the Washington Health Security Trust that has been developed by our organization, Healthcare for All Washington. Either one would be a great way to use to ERISA-proof a plan for Washington. As always, thank you for your expertise and dedication to this important work.
Thank you, Marcia. And that's all we have for signups. Is there anybody else who'd like to make a public comment? And please raise your hand in Zoom, and we'll give it just a couple of seconds here. Okay, Pam, I don't see anyone else wishing to make public comment.
Okay, thank you, Angela. And thanks to everyone who took the time to comment today. It's a very important part of our process. I'd like to welcome back Liz Arjun from HMA, who's going to briefly share where we are in the Commission's work plan and where we are headed next. Liz will also provide updates from the Commission's June meeting you can find the work plan under tab 4 of your meeting materials and the summary of the commission's July meeting under tab 5. Liz, we'll turn it over to you.
Thanks, Pam. Hi, everyone. We just want to always take a moment to remind everyone of where we're at in this process and where we've been and where we're going, because there are a lot of moving pieces. So here we are at July's FTAC meeting with the STAR. And today is the first of a two-part discussion on ERISA and understanding the concerns and making some suggestions to the UHCC about how they move forward on design, given some of the challenges and perhaps some opportunities so that they can move forward and they're making decisions about designing the system. After today's July meeting, the commission will meet and hear from what happens today, also identify additional questions that they may have and clarifications about ERISA. They're also, as noted by one of the commenters earlier, going to receive a presentation from Whole Washington on the health trust bill. And they're also going to hone in on the areas that they would like to focus on in terms of transitional solutions. So as you may recall, one of the charges of the commission, in addition to designing the universal system, is to also identify transitional solutions along the way that help pave the way towards that longer term goal. So after that, the transitional solutions conversation in August, then we'll come back to FTAC in September. We'll have another discussion about ERISA and then bring it back to the commission. And at that point, the commission will be voting on the report, the annual report that is due to the legislature in December. I won't go into any more detail about that, but that's what's happening over the next couple of months. So with that, I am done with that piece. And Pam, are you taking this part or am I doing this?
I thought that you were doing this part.
Okay, that's fine. I wasn't sure. I just wanted to check. So just updates, as we already briefly touched on. The commission was pleased with the discussion and suggestions that came out of the FTAC. I think they were incredibly clear in taking a very complex topic, Medicare, and how this could be addressed both in the short term and the long term. And I think just a clarification piece was great that Roger brought this up. They really want to do something about Medicare now. And that's why they want to pursue option 6, but recognize that the North Star is eventually doing something that would involve 1 or 2. And they never want to rule that out. So I think a real balance of pragmatism, yet optimism towards what may be possible in the future. So thanks to all of you for that conversation. In addition, they saw the list of transitional solutions and ideas that that emerged both from the FTAC earlier this year and from the UHCC. And because we ran out of time, again, they're going to be discussing that in August. And the decision at this point is to have them identify areas where they'd like to spend more time focusing on transitional solutions rather than coming up with any policy proposals for the next year. So I think one of the conversations that you all had earlier this year around cost containment that Bob Murray led us through is the kind of thing that I think they are going to be looking at for August. Like, do we want to spend more time as a commission understanding the various things we could be doing in the lead up to a universal system to address cost containment? So that's what they'll be doing in August, is really settling on some of those areas. Okay, and then if we want to go to the next slide. So finally, oh, hi, Roger. I see a comment. I see your hand up. You're muted. There you are. Oh, no, there you are.
Just a sidebar, to the extent that there are conversations about cost containment, I guess I would strongly, again, go back and make an encouraging comment about coordinating with the Healthcare Cost Transparency Board, because in my view, when you get in the arena of cost containment, I mean, that's clearly within their mandated direction. So I would, to the extent that the commission is thinking about something that is, I think is going to be critical, that it's coordinated with the work and the resources that the board is bringing to bear on that now.
Absolutely. I think one of the challenges, and Angela, feel free to weigh in here. One of the challenges is that we know affordability and cost containment is a problem that many Washingtonians are facing. Obviously, that's why I think there's so much energy around this commission and their work. And at the same time, there are a number of initiatives happening in the state, including the Healthcare Cost Transparency Board, trying to get at that. And so really making sure that the work of the commission brings those forward so that that everybody has a chance to see what, what we're finding, what data is out there about costs and affordability. And that becomes part of any transitional solution. So absolutely, great point. So finally, last update area from the commission June meeting is what brings us here today is ERISA. The commission revisited a number of areas that they had wanted to learn more about and hear more about related to ERISA as they can make considerations about designing the universal system, but also recognizing that there may be some, barriers that are not within the state's control. So they went back and visited the areas they wanted to learn more about, and I'm not going to read everything on the slide, but this is what these are the things that they've identified that we're hoping today's presentations can really help ground everyone in terms of really understanding the complexities and also at the same time considering some options. And I just want to, as we frame today's conversation, really think about how the Medicare conversation and reflect back on that it really was a two-part discussion. First one being informational, getting everybody on the same page, and second one really walking through some very specific options that could be explored. So that we've taken these questions and our presenters are prepared to start setting that conversation going. So anything, Pam or Angela, that you would like to add?
No, that's good.
No, I think you covered it, Liz. Thank you.
Okay.
Okay, I think I can pick it up from here. Just to, as Liz noted, this meeting is focused on information gathering and an opportunity for the committee members to discuss and ask questions to experts on ERISA. We'll be developing and acting on recommendations for the commission at our September meeting. So please listen with that in mind, because we'll be coming back needing to make decisions and think about our best advice. During the presentations, please just ask clarifying questions. Liz will facilitate questions and discussions after each speaker. And I think each speaker is prepared to leave time for that valuable exercise. Carmel is up first. And first of all, Carmel, can I ask you to help me with your last name?
Sure, it's a nightmare. It's Shachar, but Shachar is totally fine as well.
Okay, well, McEwen is a nightmare to spell, so I know what that's like to live with that. So she will be giving a brief history of ERISA and healthcare policy. Members can turn to tab 6 for Carmel's presentation. And we are really lucky to have Carmel with us today, as she's Assistant Clinical Professor of Law and Faculty Director at the Health Law and Policy Clinic at Harvard Law School. So welcome, thank you.
Thank you. It's a pleasure to be here. I feel like you guys are building towards some really innovative work. I am here to explain the ins and outs of ERISA, which may form a little bit of a roadblock in some of your efforts, but I think the ultimate story that I come to tell is that these are things that it is possible to work around, especially if you are comfortable with not letting the perfect be the enemy of the good. Next slide. So to walk you through what to expect, and I'm going to reserve a bunch of my time for questions, and I look forward to what the group has to say. I'm going to give you a brief introduction to ERISA, what it is, what it's about, so that we can all be on the same page. Then I'm going to walk you through several key cases, some of which were foreshadowed quite nicely by some of the public common questions, so thank you there, as well as talk about the potential impact that ERISA can have on universal care initiatives and other health reform. And then lastly, I'll include a brief sort of here be dragons red flag note on what ERISA might mean for reproductive health services. Next slide. So first, the introduction of what is ERISA. For some of you, it sounds like you are very, very ERISA conversant. And I think even the fact that this was flagged for us to have this conversation at a fairly early planning stage means that certainly a lot of you guys are highly ERISA conversant. So please bear with me as I just make sure that everybody has a workable understanding of ERISA. Next slide. So what is it? I keep on saying it. It sounds really pretty. I, in fact, tried to convince my husband that it would be a good name for our dog. He declined. Our dog is not named ERISA. She is named Eleanor instead. But it is the Employment Retirement Income Security Act of 1974. And what it is at heart, it's a federal statute that looks to set minimum standards for most voluntarily established pension and other employee benefit plans. And that's sort of a key understanding of ERISA is that it focuses on pensions. So it sets it up that the regulation of these types of employee plans are exclusively a federal concern because it wants to promote really standardization across the country, standardization of financial disclosure and reporting requirements, which will become important a little bit later in this presentation, standards of conduct, responsibility, and obligations so that employees understand what they're getting across the country. And it has what's called a preemption clause, where it says basically we are preempting all state laws insofar as they relate to any employment benefit plan. Now, the preemption clause is really what makes ERISA remarkable. Otherwise, it would be a fairly unremarkable statute just saying, hey, if you're offering plans in different states because you're a multi-state employer, let's keep them consistent. But the preemption clause, which says, okay, states shouldn't be regulating in this area, you are excluded from because the federal government has moved into this area. The purpose of it was to allow multi-state employers to offer a single consistent plan to all of their workers and reduce administrative and regulatory burdens while keeping administrative costs low so that the compliance burdens were very, very low on employers. The ERISA preemption clause is one of the broadest preemption clauses ever written, if not the broadest. It's truly the Serena Williams or any other sports figure that comes to mind who is the greatest of all time in terms of preemption clauses. Next slide. The challenge, as I alluded to, is that ERISA was never really intended to be a healthcare statute, but is sort of inadvertently one. So ERISA touches primarily on insurance plans in which an employer covers the full financial risk of its employees' claims for healthcare benefits, because those are a type of employee benefit plans. And here the operative is full financial risk, which means that your employer is not pooling risk with any other employers. It might be employing an insurance company as a third-party administrator, TPA, but it is bearing the financial risk. At the time that ERISA was passed, about 7% of Americans got their insurance through this type of insurance. That has since exploded. We're talking about employer-sponsored insurance covering about 159 million non-elderly people. In 2022, 65% of workers who got their health insurance through their employer were enrolled in plans that were at least partially self-funded. One thing that I want to flag here is, we're talking about a pretty key group if you're trying to build something that looks like universal care, because people who are employed, we know they tend to be higher income by virtue of their employment, and they tend to be healthier. They're the kind of people that you want in your risk pool, smoothing things out. And so not only does ERISA kind of carve them out, but they carve out exactly the people who are least incentivized often to participate in a universal plan, but are really a necessary ingredient in the stew. The other trend that I want to flag is that larger companies are more likely to offer employer-sponsored healthcare plans. About 82% of covered workers in large firms have self-funded plans versus 20% of covered workers at small firms. And as no surprise to anybody who reads the market section of the newspaper, through the pandemic and even beforehand, we've been in an era of consolidation as companies tend to get larger and larger and are more and more likely to opt for this form of insurance. So not only did the jump from 7% of Americans to the numbers that we have today is significant, but I would not expect it to go down. I would only expect it to increase. Next slide. So I've talked a little bit about ERISA upon passing, and I really think that a lot of ERISA jurisprudence can kind of be split to pre the 1990s and post 1990s when you talk about preemption jurisprudence. So we're going to do a quick short dive into some key cases from the 1990s. Next slide. So prior to the 1990s, the case law for ERISA preemption, basically when was a state kind of impermissibly moving into an area covered by ERISA, was really vague, expansionist. It was really ultimately unhelpful. The standard was that a state statute was deemed to violate ERISA preemption when it had a connection with or reference to a covered employee benefit plan. That's really broad, and it's so broad as to almost be meaningless. So in the 1990s, the Supreme Court kind of looked at the standard and thought, this is kind of an unworkable standard. And so it started to develop, not quite, I would never call ERISA preemption narrow, but it tried to develop a little bit more of a principled outlook to ERISA preemption. The most notable case is New York State Conference of Blue Cross and Blue Shield versus Travelers Insurance Company, which the gentleman from the public comment referenced. That was a really interesting, I think, relevant case because there, New York State was trying to encourage people to enroll in Blue Cross Blue Shield plans, the state Medicaid, or certain types of HMOs. And what it said was, okay, hospitals, when you charge certain codes, if the patient's coverage is one of those types of plans like Blue Cross Blue Shield, state Medicaid, a certain type of HMO, there's going to be an 11% surcharge. When you charge any other payer, it's going to be a 24% surcharge. It's a 13% higher surcharge, with the idea of massaging the economics such that enrolling in like the Blue Cross Blue Shields would be really appealing. The Supreme Court said that this law was fine. It said that state law is preempted if it has a connection or reference to an employee benefit plan. But then it said, okay, but preemption is really only limited to state statutes that mandate employee benefit structures or their administration. So what it's saying is if it impacts the choices that an employer would make in structuring their benefits, then you're in ERISA land. You can't do it. But if it has an indirect economic impact on an employer offering a benefit structure, then that doesn't count. That's not mandating anything. And if you just happen to impact the economics of these plans, that is fine. Now, as the gentleman in the public notice comment brought up, there is language saying, okay, you can get to a point where a fee or penalty would be so exorbitant as it's not an indirect. But like most things in the law, it harkens back to the famous Supreme Court utterance around pornography, which is, I know it when I see it. So there isn't kind of a hard line, okay, well, if something doubles, then that's exorbitant. There's no definition of exorbitant. It would be kind of up to the judge or the court to decide this looks exorbitant. Next slide. So after a while in 1990s, ERISA preemption jurisprudence felt very, very settled. You had this idea that if you're mandating benefits, it's going to be preempted, but if it's just indirect economic application, then it's going to be fine. And then along comes Gobier versus Liberty Mutual, which kind of puts a little bit of a monkey wrench in everything and really goes back to a very expansive view of ERISA preemption. Next slide. So this was a case about what's called an all payers claims database, which is states have them. They say, okay, if you are an insurer and you're reimbursing health claims, we want the data. And they're incredibly helpful for tracking healthcare spending, obviously, but they're also a really powerful tool for research, especially because when you look at our data versus, say, a country with government-run healthcare, such as the United Kingdom or a lot of countries in Europe, like our healthcare data is like pretty bad compared to theirs. We just don't have those kind of comprehensive registries, and all payer claims databases are a great way to approximate it. Unfortunately, some employers, Liberty Mutual, brought a case saying, well, we think that ERISA preempts reporting to the all payers claims database because ERISA has a reporting requirement. And the court agreed with employers. They said ERISA did indeed preempt here, and that the Vermont law indeed had a connection with an ERISA plan because it governs a central matter of plan administration, which is reporting, disclosure, and record keeping, and interferes with nationally uniform plan administration. And now here, an interesting side point. The way that data reporting was structured at the time of this case, there was no interference with a national uniform plan administration because Vermont was asking for the data in a format that Liberty Mutual was already compiling elsewhere. But the court, for the first time, didn't consider just the facts at hand in Gobier. They considered future problems with the uniformity in ERISA preemption jurisprudence. So they weren't just looking at, okay, is the state law itself disruptive to uniformity? They're saying, could we see down the line it being disruptive to uniformity? Next slide. Of course, not all of the justices agreed, as is often the case. Justice Ginsburg felt pretty strongly that ERISA did not preempt the all payers claims database. She said it doesn't impose a substantial burden on these plans. And she also made the point that the Vermont law and ERISA's reporting requirements were meant to elicit very different information and to serve distinct purposes. So ERISA reporting was basically built around evaluation of financial soundness of the plans. But the Vermont law was really looking at evaluating and improving the quality and cost of healthcare provided in Vermont. So Justice Ginsburg would have said two different types of data reporting, they don't relate to each other. So for a while, ERISA preemption jurisprudence was a little bit up in the air because we had the 1990s cases, but then we had this much more expansive kind of harkening back to the 80s case as the last major ERISA preemption case. Next slide. That then changed 4 years later with Rutledge versus pharmaceutical care management, which really harkened back to the 1990s and kind of it didn't explicitly reject Gobier, but kind of made it clear it's out of favor and worked to restore ERISA preemption jurisprudence. Next slide. So this was a case about Arkansas's regulation of pharmaceutical benefit managers and drug pricing, where they were trying to prevent pharmaceutical benefit managers, PBMs, from basically running generics out of the market. And what the PBM said was, hey, a lot of the plans that we administer for fall under ERISA. So by regulating what we are allowed and not allowed to pay pharmacies, you are regulating ERISA plans. The Supreme Court did not go for that. They said that the Arkansas Act 900, which was the relevant law, did not refer to ERISA because it applied to PBMs whether or not they manage an ERISA plan. And this is going to be a really key breadcrumb for us as we talk about what kind of healthcare reform can move forward. Another interesting point was that Justice Sotomayor, who wrote the court's majority opinion, really leaned heavily on Travelers, on that Blue Cross case. So she wrote that the logic of Travelers decides this case and argued that, like in New York, surcharge and Travelers, this law is merely a form of cost regulation and not primarily concerned with preempting laws that require providers to structure benefit plans in particular ways. In fact, she said that the Arkansas Act was less intrusive than the law at issue in Travelers. So Travelers becomes really the key operative case. And in fact, she does very little to engage with GOBA, despite it being much more recent. She references it maybe 3 times. And the most significant engagement with GOBA comes only briefly in a footnote in which she notes that unlike in GOBA, nobody alleged that the Arkansas Act 900's enforcement mechanisms overlap with a fundamental component of ERISA's regulation of plan administration. Now, by contrast, Justice Thomas, in his concurrence, did talk about GOBA a great deal, but mostly to say that overall ERISA preemption jurisprudence is a total mess, as I put it, or as he put it, offering little guidance or predictability. So he would just return purely to the text of ERISA and would have decided it on kind of the straightforward ground that there's no overlapping ERISA provision with the Arkansas Act. But I think it's kind of a key signpost that I think the court feels a little bit unsettled in its ERISA preemption. And even though Rutledge, I think, is really good news and gives people looking to do innovative things in healthcare a little bit of space, I wouldn't necessarily count on it being the absolute last word in ERISA preemption. Next slide. Of course, we're interested in ERISA preemption, not because ERISA is deeply fascinating, but because it has the great potential to block innovative healthcare reform. Next slide. And in fact, that sense is correct. So ERISA preemption really prevents states from regulating a significant portion of their health insurance market, the employer self-funded plans. And it really can prevent people from moving to something like single payer or universal. Now, 2 of my colleagues, Erin Fuse-Brown and Elizabeth Mikulski, did a really interesting project where they analyzed various proposals that came to in various states from 2019 to 2021. And they kind of tried to see, okay, does ERISA preempt or not preempt reform in this area? And there were definitely some areas where it might. In general, they found that when the reforms focused on actors outside of insurers, so when you're talking about PBMs in the Arkansas case, when you're talking about hospitals in the Travelers case, you're on firm footing. And then as it gets closer and closer to directly impacting the choice of the insurer/employer, it gets on shakier and shakier ground. Next slide. So before we talk fully about the impact on universal care, I just want to use GOBA as kind of a canary in the coal mine test case about what's at stake. So GOBA, as decided, it's still good law, has really significantly reduced the volume of claims data available to the all-payer claims databases. So some states have asked employers to voluntarily submit data by entering into data sharing agreements. It's unclear exactly how, say, like HIPAA applies to those. But a lot of employers and third-party administrators are just not willing to do so because they're worried about the liability of voluntary disclosure. This means that we lost some really good tools, for example, for understanding what was going on exactly with COVID and doing good research to understand, okay, what interventions might have been successful in the pandemic. But it also shows that ERISA fixes are unlikely. If you're holding out for a hero, you might have to hold out for a pretty long time. So Congress could just easily carve health plans out of ERISA, and they have shown very little interest in doing so. For GOBA, the Department of Labor and Health and Human Services could work together to create carve-outs, and they did issue preliminary rulemaking, but it didn't really go anywhere. And reporting to all players claims databases is a much smaller issue than moving to universal healthcare. And if there's no proactive attempt to smooth that path, again, I don't think that Congress or the federal agencies are necessarily going to be the solution to the problem. Next slide. So let's talk about ERISA's impact on universal care attempts. And here there's really two cases that sit on either side of the line there. The first is a case from Maryland, Retail Industry Leaders Association versus Fielder. And that's from 2007. This was a law that really was targeting Walmart as an employer. And it said that employers with more than 10,000 employees had to spend a minimum of 8% of their payroll on healthcare, or else pay the difference between their actual healthcare expenditures and the 8% threshold into a state Medicaid fund. So their options really are raise your healthcare benefits to 8% of your spending, or pay it into the Medicaid fund. The Fourth Circuit struck down Maryland's law. They said that it wasn't an indirect economic impact, but instead it was really mandating benefits, because Walmart essentially would get nothing by putting money into the Medicaid fund, only bad press. So the only rational choice was to spend the required amount on healthcare benefits. And so they said, you're forcing Walmart's hand to make its benefits more robust and well-funded, and that interferes with the uniformity of its plan across state lines. Now, a little bit later, the Ninth Circuit took what was like a distinguishable but still overall pretty similar case, in which San Francisco had a tax based on hours worked. And it said, okay, employers, you can do many things with the required expenditures. You could use them to make your benefits more robust. You could plow it into your own health plan. You could use it to buy a different health plan. You could use it in the alternative that we've set up for low to moderate income residents. So kind of coupled with this payroll expenditure requirement was setting up this new healthcare program. We don't care what you do as long as you meet the required rate and total spend. And the Ninth Circuit there said, okay, we observed that this ordinance didn't force the creation of ERISA plans, require employers to start offering health plans or change any existing health plans, or demand that they provide specific benefits in any particular way. All the ordinance does is say how much you need to spend, doesn't scrutinize how, and combining that required expenditure rate with really broad discretion in how to spend it meant that it was even less direct influence on employer benefit decisions than the Travelers case, as well as the fact that the new San Francisco health insurance plan offered a meaningful alternative for employers. So there were rational choices left open to employers as opposed to the only one rational choice left in the Maryland case. So the Ninth Circuit has continued to be friendly to this line of thinking. It more recently upheld the city of Seattle's attempt to do something similar aimed at employer health care contributions for hotel workers. But other circuits, I think, are a little bit closer to Maryland. So like the first, there's a case out of New York in the second that are much closer to Maryland's. And you can see how the ninth is kind of trying to find space from Fielder. But at the time that Golden Gate happened, there was kind of a big expectation that it would make it up to the Supreme Court because it's kind of a circuit split. It didn't. I think the good news for you guys, like Ninth Circuit, this like language gives a lot of room to use, not quite pay or play, but to use pay or play or meaningful alternative structures. But if a case with this fact pattern went up to the Supreme Court, would they necessarily go with the Ninth? Or would they go with the Fourth Circuit? That I wouldn't necessarily say that they would go with the Ninth Circuit. So there is a little bit of ambiguity there. Next slide. So before I wrap up, I want to flag a little bit the impact that this issue that ERISA can have on reproductive care, because that's also very much in the news these days. You know, Dobbs has really, I think, splintered the country when it comes to access to reproductive care. Now, self-funded plans can likely cover abortion services and care, even in states that ban abortions. Because remember, there's preemption. And now it's a question, does ERISA preemption apply to state criminal laws? But overall, like these self-funded plans are actually beyond the reach of state regulation. It might be a paper victory because employees would struggle to find providers in state. They would be subject to state laws banning reproductive care services. And as I said, nobody knows if ERISA is a shield against criminal liability, but it might also be an issue in that the flip side, the state can't require employer plans to offer reproductive services. They just like can't really regulate the direct benefits package offered by ERISA plans. Now, the Biden administration is supportive of access to reproductive care, but could a subsequent administration that was anti-abortion have its Department of Labor issue regulations saying no ERISA covered plan could support access to abortion services? That would be in the purview of the Department of Labor. And that might also cause some complications, especially if you think of universal care as kind of universal care to all of the medical services necessary for people, including reproductive care. Next slide. So with that, I want to thank you for giving me a little bit of your time to do a brief romp through ERISA jurisprudence and to talk about how it kind of implicates building access to universal care. I'm really excited to answer any questions that you guys might have. All right, so Angela, should I call on people or?
Yeah, that's fine, Carmel. I think I saw Christine's hand. Yeah.
Christine?
Sure. Yeah, I just have a quick question about the Golden State ruling. It didn't make it up to the Supreme Court. Can you tell us why? Was it just not challenged, or did the Supreme Court refuse to hear it, or something else?
That is a great question that I need to look up necessarily. Yeah, I'll follow up and let you guys know because I just need to pull the records.
Thanks.
Okay, Roger.
Thank you. I was going to ask the same question, so thank you for that. I know we're not going to spend a lot of time today on necessarily, strategies to kind of, if you will, work around ERISA. But could you talk a little bit about, I guess one that always comes up is around pay or play. And the other kind of is this notion about the ability to regulate providers in a general sense, recognizing that they're not plans in themselves, but I know there's been some cases and activity around trying to direct providers in one direction or another.
Yeah, so I think providers, the states are actually on really good footing in that, you know, it kind of gets away from, are you directly regulating the employer / funder of insurance? And in the ERISA jurisprudence, it has been kind of historically acknowledged that the states are the traditional regulations of medical providers. So, you know, there's other kind of legal questions to think about, like if you just said, okay, providers, like you are only allowed to bill the state program, you're not allowed to bill anyone else. You're going to have some physicians who are going to be pretty upset and going to start looking for various legal theories as to why you're impeding their freedom of contracting. It's a state takings to take their ability to conduct their business as they want. Like, there are certainly ways that you could provide incentives saying, okay, if you exclusively bill with us, like we will give you a much better rate, or if you bill with us, like we will go after employers' self-funded plans for you so that all you need to do is deal with like us and our compliance requirements, which honestly I think would be a pretty big incentive for physicians, because dealing with various payers is just like a nightmare for offices. But I think in general, especially travelers, like if they can dictate what hospitals charge and how they differentiate between plans, they can probably dictate how providers differentiate between plans.
But can I try another one real quick just to play off of that? I'm sorry, I'll be brief. So if there's a situation where there was, you know, a single payer system and said, I'm thinking mostly of hospitals, a great example. If you want to be a participating or performing provider, obviously you have to contract with our plan, and the provision of that is that you accept, no other entities. Essentially, if you to that, so restricting those provisions seems to me that could be subject to an ERISA challenge. And some self-employed employers are arguing, well, these actions are essentially denying us the ability to implement in this case, a health benefit. So that would be kind of the other extreme. And I guess I'm hearing you suggest that would be likely more subject to an ERISA challenge.
Yeah, so I think like the trickiness is, again, ERISA is not a healthcare statute, so it actually has like remarkably little detail. So at what point could you argue, like from the provider perspective, well, you are free to construct any plan benefit you want. It's not our fault if you can't find physicians in the state to provide those benefits. But I would say that the more kind of controlling and restrictive any scheme will be, sort of the more it looks like you're providing sticks to corral the providers as opposed to carrots, like the more nervous a court will be that you're really mandating certain benefits. And frankly, the more nervous, the more it might look for reasons why, okay, this smells funny, so there must be something rotten here.
Thank you.
See Dave and then Eddie.
Thank you, Carmel. I thought your overview was fantastic. I have two questions. One, I think I'm on the same or a similar train of thought as Roger. One of our fellow committee members, Bob Murray, talked to us about the hospital budgeting system in Maryland. I'm wondering if you're familiar with that and if that required an ERISA waiver of some sort.
As far as I know, it did not, because it was kind of focused on the hospital side. Okay, so is that where you and Roger were going, where the state
could come up with a universal pricing or reimbursement scheme that is outside the purview of ERISA, but could have a significant impact on overall expense in the state?
Yeah, I think as long as you focus it on, okay, here are what hospitals and providers are allowed to charge, as opposed to, okay, here's what insurers are like. I think as long as the law is kind of keyed to the provider side, it has that indirect economic impact on ERISA plans, sure, but it's not mandating any specific benefits. Like a rational actor could still design a benefit package as they see fit.
Okay, got it. And then the second question, just to crystallize, I think the punchlines of your presentation, it sounds like the pathways to dealing with the challenges imposed by ERISA, one would be an act of Congress, which I think was similar to where we landed when we were talking about option 1 and 2 for Medicare. And the second pathway is this pay versus play versus meaningful alternative. Are those essentially the two potential pathways?
Yeah, I think so. Like, could the Department of Labor find sort of ways to help give you a little bit more room? Maybe, but it's not like really a Department of Labor core competency. So I think you're either waiting for Congress to really revisit ERISA, which I just don't see happening, or you're kind of using the Golden Gate language and hoping that's kind of the one that sticks.
Okay, and then in that case, it isn't a truly, it's not a mandated universal system. It would be an achieved universal system because the actors aren't opting for the meaningful alternative. They're going for, however the state designs the universal system.
Yeah, so I think the universal system is kind of that meaningful alternative. That is to say, like, you're still allowing an employer to say, no, I still want to design and offer my own benefits plan, or I'll pay into this other fund, and I know that my employees will be able to access healthcare that way.
Okay, got it. Okay, thank you.
Eddie.
Great questions and just more thoughts. Thank you for the history lesson. For the ERISA preemption, I was trying to look at the slide that had Globier as a test case. And is that kind of a litmus test for, them using that as a shield to, provide data that wasn't even, there's no monetary impact to providing data to an all payers claim database. That's just personal information, but it's not even that, it's removed. So it feels that that's a kind of outside of the wheelhouse of what ERISA was set up to do in some ways, but it was used for that anyways.
I think that's what makes this case like so interesting and such like the high watermark is that, if everybody who's pro ERISA preemption is banging the drum of like, we want uniformity, we want ease of compliance, we want to limit administrative burdens, like reporting data that you already have in a format that you already have is like probably like the least onerous obligation. And to add to that, like ERISA does have reporting requirements, but they are like reporting completely mutually exclusive things from what the all payer claims databases wanted. And so the fact that the court still found it to sufficiently relate to ERISA reporting requirements, like leaves me to think that, a fairly modern composition of the court would still have some appetite for ERISA preemption. And like I was really heartened when Rutledge came out and kind of walked it back and said, no, like ERISA shouldn't be used as a shield against healthcare reform efforts and cost control efforts. But GOBA is like still good law, and like it's very possible that at a future ERISA preemption challenge, the court would decide that it likes GOBA better than it likes Rutledge.
Yeah. And so you'd said that there's no future that ERISA is going to spin off medical and focus on retirement, so that you're going to be dealing with this. And you said it's somewhat vague. As a tangent, is workers' comp self-insured also under ERISA? I just wanted to know if you knew that answer.
That
As an-
is,
As an example, because our state has a self-insured and a state fund, and it's about a third, 2/3 type of, and I was wondering if that is a harmonious thing that actually works in having part of it in ERISA and part of it outside of it. Does anyone know?
I believe it's self-funded, and I don't believe it comes under ERISA.
It doesn't.
So, and it is harmonious. I think there's.
Well, it's a good example.
It works well, and they collaborate. They play well with others.
Yeah.
I see Roger's piping up, yeah.
Hey, Pam, this is a follow-up to that and to our colleague's question. My understanding, I could be wrong in this, so in Washington State, we have a health benefit. A chunk of it is what they call the Uniform Medical Plan. And the state contracts with regions as an ASO, but the state is the risk-bearing entity for those state employees who elect to go into that plan versus going into a more conventional health plan, such as Kaiser would be in our state. So the point being is, my understanding, Pam, maybe you clarify this or not, that UMP is governed under ERISA.
So
the other piece is for other employees where they elect to make a decision to go into, let's say Kaiser would be the case, then those employees, of course, Kaiser are not under the ERISA provisions.
I think you might be right, but I think we've got a lot of healthcare authority employees on our call. But I believe that is
I should direct that.
I think ERISA doesn't. Yeah, I did want to say one thing about kind of the earlier discussion about the all-payer claim database, because we've had that debate in our state as well. And there was an issue between the carriers and the self-funded plans, or really the third-party administrators and the providers, which it came down to a proprietary relationship between the providers and the carriers or whoever the third-party administrator was and the employer. And they played that card pretty heavily about not having to share data, that they would be violating proprietary interests. Whether you believe that was as big a risk as they claimed it was or not, that is definitely what carried the day in terms of not being able to access the data here.
Yeah, and then I also want to follow up on Christine, I believe's excellent question of why didn't the Supreme Court do anything about the apparent circuit split? And I double checked, cert was denied by the Supreme Court. This was a case that they had discretion whether or not to hear. And so they may have said, okay, we are comfortable with how the Ninth distinguished itself from the Fourth. We don't think this is such a pressing issue. And they only have so many hours in their day. I assume it's the same 24 hours that we have, but who knows?
Yeah.
And so I think probably looking at everything else that was potentially on the docket, they said, this isn't pressing enough for us to resolve now.
Yeah, I want to move us along just because of the time. I feel like there's still some questions and issues here that are unanswered, and some little things that have been opened about looking at examples within our state of self-funding and what the impact of that is. So I think we can come back to those, but I want to move on to Jane. And I think actually at one point, Jane even had her hand up to jump into the discussion. So, but she'll be able to get to do that as our speaker. So we are going to hear from Jane Beyer, who's going to present on ERISA issues in Washington State. And I think may be able to answer some of the questions that arose in the last conversation. Her presentation's under tab 7. And I just want to note that Jane is a member of our own Universal Healthcare Commission and the Senior Health Policy Advisor at the Office of the Insurance Commissioner. And Jane's been a leader in ongoing efforts to improve our health system in Washington State. And so she can give us some important historical perspective as well as a good understanding of our current state of ERISA in Washington. So welcome, Jane, and happy to turn it over to you.
Thanks, Pam. Raj, to answer your question, ERISA applies to private group health plans. So state and local government self-funded health plans are not regulated under ERISA.
Thank you, I forgot.
And then when we think about how often the state legislature regulates the Uniform Medical Plan, that's perfectly appropriate because the state is the purchaser and the state legislature can set policy around what it will purchase, what health benefits it'll purchase. So the Uniform Medical Plan has about 380,000 enrollees. So there are 380,000 people in Washington State that are in a self-funded group health plan that we can indeed regulate. So just to give you that background. So Pam, thanks for the intro. So I'm going to talk about several examples of where ERISA issues have arisen in Washington State and talk through those so that we have an understanding of sort of what's been tested, what's been done, what's been challenged, what's not been challenged in Washington State around ERISA. So next slide, please. And I always, next slide. I always like to start a discussion, and Professor Shachar really sort of pointed it out. But if you look at this pie chart or this pie graph, you'll see that, as she indicated, about a third of the people in Washington State get their coverage through self-funded group health plans. The Office of the Insurance Commissioner regulates those fully insured health plans, the plans where the employer says, you know what, I'm not comfortable taking on all the financial risk. I'm going to contract with Premera or Regence or United or Aetna and let them take the financial risk. So, and you can see about 11% of the population is in the large group market. So that's in the neighborhood of 700,000 people. There's about 250,000 folks that get their coverage through the small group market. And then the individual market, the health benefit exchange, is about 200,000 folks. And then we all know Medicaid covers about 1 in 5 people in the state, and Medicare about 1 in 6 folks. So so when you think about what OIC has jurisdiction over, we have jurisdiction over individual health plans, small group health plans, and large group health plans. I always like it. I especially like to do that when I'm talking to consumers who think that when the legislature passes a law mandating a benefit, it's going to apply to everybody in the state. And then I have to explain this, and then they're very unhappy with me. So let's go to the next slide. So let's talk about where ERISA has come up in Washington state health policy. And what I wanted to do also is, keying off of what I said earlier, let's think about the different kinds of health plans that are out there and who regulates what. So fully insured health plans, OIC regulates. Private self-funded group health plans that the states can't regulate, it's actually the Department of Labor Employee Benefits Services Administration, lovingly called EBSA. And then state and local government plans like the Uniform Medical Plan, they are accountable to HHS and the Centers for Medicare and Medicaid Services. And just putting universal health care out there, in this case, we assume the system would be regulated by an entity that's been established by state law. And then when we think about required benefits, fully insured health plans have to provide benefits that are mandated by both federal and state law. But private self-funded group health plans and state and local government plans, their obligation is to comply with federal laws. So for example, ERISA, and then HIPAA around health insurance privacy, and COBRA coverage for people who leave employment and get to pay for their benefits. The American Disabilities Act, the Mental Health Parity Act, the Affordable Care Act's preventive services requirements, the Pregnancy Discrimination Act, and then most recently, the No Surprises Act. And in a universal healthcare system, yes, the benefits would be defined by state law. I would think that that even a state established entity would still need to apply with the federal laws that apply to all health plans. And then an issue that always comes up is provider network adequacy. So in Washington state, we define it in state law, plus the Affordable Care Act sets that for qualified health plans. Private self-funded group health plans, one of the big issues is that there are no federal standards around network adequacy. And that's been sort of controversial. Indirectly, there's some network adequacy that comes in on through the side door via mental health parity. But, and then state and local government plans that are self-funded, they can set their own network adequacy standards. And one would assume that if we did a universal healthcare law, that would be addressed somehow in the law. And then eligibility, basically for fully insured health plans, it's the Affordable Care Act and state law that addresses that. With respect to private and state and local self-funded group health plans, basically it's set by the plan. Indirectly, eligibility criteria can't be blatantly discriminatory. So like HIPAA and the American with Disabilities Act. And again, we presume eligibility would be defined by state law. So Angela asked that we just sort of lay this out to give folks a sense of who does what with respect to these different plans. So hopefully that's helpful. Next slide, please. So for those of you who've been around a while, Roger amongst us, back in and I think Roger Collier as well, back in 1993, the state did pass a major healthcare reform law called the Washington Health Services Act, and it did include an employer mandate to offer coverage, starting with employers of 500 or more employees in 1995, and then extending out to every employer by 1997. And it was via requiring employers to purchase certified health plans, which are sort of like managed care organizations, or to enroll their employees in the basic health plan or a health insurance purchasing cooperative that was established under that law, the Health Services Act. There was sort of special treatment, distinct treatment given to Taft-Hartley trusts to for a variety of reasons that I'm not going to go into here, but they were given distinct treatment. And this issue of what ERISA would do was very, very definitely front and center, because the statute directed the governor to negotiate with Congress to try to obtain a statutory ERISA waiver. But then, as many of you know, in 1994, there was a big sea change in election results. Republicans took over the state house, and I think if they didn't control the Senate, there was a super narrow Democratic majority. And so the employer mandate and several other provisions of the Health Services Act were repealed in 1995. So we never really had the opportunity to have the discussion with Congress about an ERISA waiver. So that was the one that's most analogous to the Universal Healthcare Commission and what we're looking at there. But next slide. Let's talk about some more focused efforts that not only have survived an ERISA challenge, but no ERISA challenge was ever brought. And that is the Washington Vaccine Association. It was a law that was enacted in 2010. Some of you might remember that 2009 to 2011 was a horrible year fiscally for the state of Washington, and there were all kinds of horrible budget cuts that had to be done during that recession. And the legislature prior to 2009 had put about $50 million either a year or a biennium into buying childhood vaccines, including for privately insured kids, so that we could have a universal system of access to childhood vaccines, because that was such an important priority of the legislature. But in the 2009 budget, the legislature said, we cannot afford to do this anymore. And so they tasked the Department of Health and others to basically pull together a group during the legislative interim and come up with a way to maintain universal purchase of childhood vaccines. And so basically have the same system where the State Department of Health is purchasing vaccines for all children at a volume discount. Remember that, that's important. It was at a discounted rate, and then deliver them through a single distribution system to any healthcare provider in the state at no cost to the provider. And so the alternative was to have health insurers and third-party administrators of self-funded group health plans have to start paying for those themselves and going out and buying them, notably not having access to the federal discounts that are available. And so after a whole bunch of discussions, the health insurers and all of the major third-party administrators of self-funded group health plans said, yep, it's definitely a better deal for us to get the vaccines off the federal supply schedule, number one. And number two, we don't want to jeopardize kids' access to childhood vaccines. So they essentially agreed that they would pay an assessment into the Washington Vaccine Association. The Vaccine Association collects all that money, gives it to the Department of Health. The Department of Health buys the vaccines, and they get distributed through this one single system. What was notable about this, and I actually staffed this, so I remember these discussions, this was when I was the legislative staffer, that there was a big discussion about using a dosage-based assessment or a covered lives approach. And a covered lives approach would basically be, okay, Primera, you cover 1.3 million people in the state, so you're going to pay in X cents per member per month for every person you cover, and that's how we're going to finance this. But because this was the first time anything like this had ever been done in the state, the insurers and the third-party administrators were like, you know what, just wait a minute. I don't want to have to pay an assessment for somebody else who has higher, for example, immunization rates. So my assessment is going to be based upon how many doses of vaccine are actually administered to my enrollees. And that's the dosage-based assessment. And so that was a deal that was developed, and third-party administrators, all the third-party administrators in Washington state were required to register with the Vaccine Association. So we actually have sort of the Vaccine Association, we know how many self-funded lives there are. So let's go to the next slide. And this is just a slide about what I just described about how the vaccine assessment works. And every year, based upon what the cost of vaccines are on that federal supply schedule, the Vaccine Association sets the amount of the assessment, and that's what the health plans and the third-party administrators pay for each vaccine dose that's administered. And as I indicated, while we knew there was a risk under ERISA, because we were telling self-funded group health plans how they had to administer childhood vaccines, there was never a challenge on that one. So let's go to the next slide. So the next time that came up was more recently. There are programs in Washington state called the Partnership Access Line. The Partnership Access Line is beloved by primary care docs and pediatricians and others. And essentially any pediatrician or OBGYN or other mental health provider that's caring for a child or a pregnant postpartum person can like literally call this line and talk to a psychiatrist. Like if they have a kid in their office and the kid's 4 years old and they don't know how much they should dose the kid on an antidepressant, they have access to that person. And we now have the same kind of a service for hospital emergency departments and local jails. And when this program was originally set up, it was set up to be insurance blind, and it still is. Nobody's going to ask that primary care provider whether the kid they're caring for is covered by Medicaid or Premera or anything else. But when it was first funded, and for the several years that it first operated, it was funded with all Medicaid funds. And so the state was at risk of having the feds come down and say, no, 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 no. Half of the people that are being served through this program are not Medicaid eligible kids. You can't use Medicaid funds to serve Medicaid eligible kids in this way. So next slide. So basically, the legislature said, good point. We don't want to risk CMS yanking Medicaid dollars from us. So we're going to figure out an alternative way to finance the program. And that was done in RCW 71-24-064. So basically, we have the WAPAL fund, and it's a blend of Medicaid and assessment funding. And so for privately insured kids, there is an assessment on payers. And notably, the definition of payer includes health insurers and employers or other entities that provide healthcare, including self-funded group health plans. And the payers report quarterly how many covered lives they have. And you can see here a covered life is a Washington resident for whom an entity administers or covers healthcare services. And then every year, an assessment, a per covered life assessment, is calculated to cover the cost of the program, the portion of the program that is not funded by Medicaid. So it's $3.5 million. It's not a boatload of money. It's 7 cents PM per covered life. There was, again, here's another program where there was not an ERISA challenge. People talked about ERISA when this bill was going through, but no ERISA challenge. And here again, you sort of think, okay, it's 7 cents PM, right? It's like less than $1 a year. And from the employer's perspective, who's a self-funded employer, but look what look what my employees are getting access to. Their kid's pediatrician can call this line and get this awesome service. So next slide. So now the interesting thing is, let's think about now. So the legislature passed this bill to fund the PAL program with a covered lives assessment. In the operating budget that was just enacted by the legislature during this session, many of you have probably heard about the 988 line and the fact that anybody can call, text the 988 line if they're experiencing a behavioral health crisis. And the idea is to have a system underneath that line so that if somebody needs crisis services, they can get them if they need something more than just talking to somebody on the crisis line. And right now, the state's behavioral health crisis system is funded largely with Medicaid funds and federal block grant funds and state general funds. And so the legislature has directed the healthcare authority, the Medicaid managed care organizations, the behavioral health providers, the insurers, self-funded organizations, and the OIC and crisis providers, basically to assess gaps in the current funding model for crisis services and recommend options for addressing these gaps, including but not limited to an alternative funding model for crisis services. And that reference to alternative funding model is essentially a covered lives assessment. And funding the behavioral health crisis system is a lot more expensive than $3.5 million. So this work is getting started by the Healthcare Authority now. And there's a preliminary report due to the legislature in December and a final report due next July. So this issue might be front and center with the legislature next year to talk about whether a covered lives assessment is an appropriate way to fund the behavioral health crisis system, which again is an insurance blind system. It doesn't matter. Nobody, when you call 988, they don't ask you first thing, I know you're in a crisis, but where do you get your health insurance coverage? That does not work. Next slide. So again, as I indicated, I basically talked about all these things. So, and you can see the covered lives, the code for covered lives is the bullet that says determine the annual cost of operating behavioral health crisis services and collect a proportional share of the program cost from each health insurance carrier. And the definition of, and I think when the legislature was thinking about this, they used the term carrier a little bit too narrowly, but that'll be what's discussed in this work. Okay, next slide. So here is another very current ERISA issue. Professor Shachar talked about PBM regulation and the Rutledge case. There was legislation this session which did not pass that would have expanded regulation of pharmacy benefit managers to include contracts with self-funded group health plans, as well as the insurers that OIC regulates. And the discussion around these provisions very much became an ERISA discussion, because the discussion became, let's look at what Arkansas was regulating in their law that was upheld in Rutledge. And then let's look at other provisions that the the community pharmacists and some other states have incorporated into their laws. And the way, at least the way that helps me think about it, is a distinction between PBM business practices and plan design. So just as an example, a PBM business practice, the PBM's relationship with their pharmacies that they contract with, the Arkansas law that was passed said that a PBM has to pay a pharmacy at least as much as what the pharmacy had to pay for that drug, and then set up a system of appeals for pharmacies. And so the Arkansas law dealt mostly with the PBM's relationship with the pharmacies. Laws since then, most notably in Oklahoma, and then also North Dakota did a bill as well, are starting so they're expanding this concept of business practices. For example, spread pricing. So if I'm a PBM and I pay the pharmacy $5 for a drug, and I turn around and bill the carrier $15 for the drug, I'm keeping the spread. I'm keeping $10. And so several legislatures are really, and Congress are thinking, hey, wait a minute, we don't know if we like this spread pricing idea. And that's a business practice. But then you'll also see other provisions in these state laws that really get at plan design. For example, saying that you can't make it cheaper for an enrollee to get their drug from a mail order pharmacy than a retail pharmacy. That kind of looks and smells like plan design. And or consumer cost sharing has to be the same regardless of whether it's a retail network pharmacy, a mail order pharmacy, or a PBM owned pharmacy. And there's a court, we're awaiting a decision right now out of the 10th Circuit regarding Oklahoma's PBM law. It's Pharmacy Care Management Association versus Mulready. And everybody is awaiting that decision. There was also an 8th Circuit decision that upheld North Dakota's law that was that was not, I'm trying to remember in Wabi, was there a petition for cert? I can't remember whether the North Dakota case had a petition for cert. Either there was no petition for cert or there was and the Supreme Court denied it. So now the case has been argued in the 10th Circuit. It's been briefed. Interestingly enough, the 10th Circuit asked the Department of Labor to file an amicus brief and weigh in on where DOL was on the ability of states to regulate pharmacy benefit managers. And their brief actually took a pretty expansive view of how far the states could go. And then the Pharmacy Care Management Association, in their response to the Justice Department brief, basically said, no, that's way too far. So everybody's waiting to see what the 10th Circuit is going to do. Senator Cooter and Senator Short were the sponsors of Senate Bill 5213. And our understanding is that they plan on pursuing the bill again next session. So there will undoubtedly be ERISA discussions next session. And I think that's it. Yep. So happy to take questions.
All right. Thank you so much for all those examples, Jane, too. Roger.
Yes, good. When I should have asked of Carmel or you too, Jane, where do Taft-Hartley trusts, since I didn't fall into this discussion?
Taft-Hartley trusts are a type of ERISA plan. Unless they're state or local government,
Gotcha.
right? If you've got a private employer that enters into collective bargaining and sets up a Taft-Hartley trust, that's an ERISA plan.
So can I push that just a little further? But I'm trying to think.
And Professor, let me know if I'm wrong.
So let me ask a little differently. So I'm a union and I've established, I understand Taft-Hartley. This plan, and it's through my union.
Mm-hmm.
I mean, I'm not saying there's not employer contributions to that. Obviously there are.
Mm-hmm.
I, the union, the holder of that benefit, that medical benefit. Again, it falls in that same bucket because it's not a public entity. Am I getting that right?
Mm-hmm.
Okay.
So we can't regulate Taft-Hartley plans the same way we can't regulate private self-funded group health plans that are exclusively administered by the employer or offered by the employer.
Okay. Okay.
Yep.
All right, David.
Thank you, Jane. That was a fantastic overview, at least for me. Do you anticipate that the behavioral health crisis assessment will raise ERISA challenges?
It could. I mean, it's so interesting, right? Because when you think about Travelers, when you think about Rutledge, the court was like, it's okay to impose additional costs on a plan. And it's that question of how much is too much, right? So if in order to fund the behavioral health crisis system, we end up with an assessment on self-funded group health plans of, $5 PM, is that too much when you recognize that by virtue of paying that assessment, right, the plan isn't going to have to pay for those services, because now we've turned the behavioral health crisis system into a firehouse model where everybody pays in and everybody gets served. So it's definitely a matter of degree. I think how much it'll be really interesting to see what the discussions are in that working group. I can tell you that back in 2018, the insurance commissioner proposed a reinsurance program for the individual market, because remember back then the market was pretty unstable. We had a couple of Air counties potentially. The OIC proposed a reinsurance program. The funding gap that we needed to fund was about $150 million a year. And we proposed a covered lives assessment to fund it. And I will tell you that the Taft-Hartley plans were very, very vocal about not wanting to do a covered lives assessment and the private employers were as well. But from their perspective, it was like, well, heck, why should I pay a covered lives assessment to support the individual market when I'm out here providing health benefits for my employees and paying full bore for it? So think about the distinction, right? With the reinsurance program, it was an assessment to fund something the employer or the Taft-Hartley plan wasn't going to benefit from directly. But with the Vaccine Association, with the PAL program, potentially with behavioral health crisis funding, there's a direct benefit to the employer.
Got it. Yeah, that makes sense. Can I ask you from a procedural standpoint, what does an ERISA challenge look like? Like, does the aggrieved party call the Department of Labor and then the state has a chance to back off, or how does that happen?
Procedurally, generally, what happens is, for example, with Rutledge and with Go Bay, right? Liberty Mutual filed a case in federal district court. And with Rutledge, the Pharmacy Care Management Association, which is the big trade association for the PBMs, filed a federal case in district court. It's called federal question jurisdiction. So in essence, they're saying to the court, we need you to review this state law and opine as to whether this state law violates federal law. And then the question is whether the district court would put a stay on implementation of the state law pending it making its decision in the case.
Okay, thank you.
All right, Eddie.
I think you're on mute. I think you're on mute, Eddie.
Sorry about that. On the graph, the pie chart that had self-insured at 35%, that's the self-funded group that you're talking about?
Yep.
Okay. It doesn't include the small or the large market. That's
right. Those are separate.
Okay, got it.
Roger.
Yeah, just a quick definitional one. On this, I noticed here we have under self-insured. I've heard the term before, partially insured.
Yeah.
Related to ERISA. A definition of what that means?
Yeah. So what we are seeing now more often, especially with small employers, is they are quote unquote doing what are called level funded plans or partially level funded plans. And essentially in that case, what happens is, I'll use an example. United Healthcare offers level funded plans to small employers. So essentially what happens is United Healthcare is administering that employer's self-funded plan, but they're also buying stop loss coverage from United Healthcare.
Oh, yeah.
And so the issue that's come up is, what's the attachment point for that stop loss coverage? And when has the attachment point gotten so low that really it's like you're buying health insurance? In Washington State, we actually regulate how low the attachment point can go, but other states don't. And so actually in the proposed rule that came out of the White House on the 7th, that's the Association Health Plan, in short, the junk plan rule. They actually also have a request for comments about whether there should be some restrictions on like this trend to level funded plans. Because if you look at the Kaiser Family Foundation annual employer benefit survey from last year, they saw a big jump in level funded plans by small employers, a big jump.
Thank you.
We have about 5 more minutes for questions or comments or discussion. I mean, I have to say, like, this is really, I don't know, it's getting my brain thinking about different things, and I'd love to hear what FTAC members have to say. Eddie.
Oh.
Your hand's up again.
Yep. If no one else had a question, what made the Vaccine Association successful? Because it was an example of, something that didn't look like that would happen.
Okay, I think absolutely what made it successful was we spent an entire legislative interim with everybody sitting around the table together. The kids advocates, the pediatricians, the primary care docs, the medical association, all of the carriers, the entities that several TPAs, and we hashed it out. That was one thing. The other was that there actually was a financial benefit to
Yeah,
the
were the
carriers.
PBMs and the carriers, was this like a 2x benefit to them? I mean, how much was,
That's a really good, I can't remember how much of a benefit it was, but
So
the purchase of the vaccine on the federal supply schedule was definitely less expensive than going out and just buying it directly
So
from
the-
manufacturers or distributors.
the largesse, we were able to actually eclipse the pricing that they could get in some fashion.
Yep,
Wow.
yep.
Thank you.
Christine.
Yeah, I'm just wondering about sort of the viability of just taxing employers generally, if not specifically employers that are currently offering insurance. Just to say, we're going to increase taxes for some reason. I mean, I'm probably putting this too bluntly, but the state has the power to tax. That goes into a general fund, and then the state uses the general fund to fund some priority, which could be healthcare. I'm wondering where that line is of coercion, particularly if you have, I guess, has that been tested where it's like a broad-based policy that applies to all employers, not simply based on whether they offer health insurance or the number of covered lives?
I am not aware of that. I think that is in essence what Oregon is proposing, right? Let's do a tax on employers and say to them, whether you offer coverage or not, you're paying this payroll tax. And so if it's in your financial best interest to go ahead and pay the tax and enroll your employees in the universal healthcare system. But I am not aware of a similar concept being challenged. I don't know if Professor Shachar is.
Nope.
Christine, do you have another question? Okay.
No, thank you.
And Eddie, your hand was up again. I don't know if it went back down or.
Just to follow up on the other one, the crisis funding. So in both of these, it had a PMPM kind of impact, but it would be really hard to see. Was there any like follow-up studies done that would show that, offloading that did reduce plans pricing in some way?
So the vaccine is, boy, that's so hard. I mean, there's so many.
Tiny.
Yeah, Eddie, there's so many things that impact premium. All I can say is the Vaccine Association has now been operating successfully for 13 years, and I have not heard anybody say we shouldn't continue on that path.
Thanks.
I can tell you that much.
Christine?
Sorry, I just forgot to lower my hand.
Okay. All right, Roger?
Jane, it seems to me, and Carmen, one of the principles I'm using, thinking of the vaccine program and the one we're talking about now with the mental health aspects. I mean, isn't one of the arguments there is we're not impacting how a self-funded plan defines its benefit or purchases that benefit. So it seems to me we're kind of creating, lack of better words, a safe harbor for the the self-insured entity to administer this health benefit in the full spirit of ERISA.
Yeah, I mean, under the PAL system, the PAL funding, for example, an employer could pay the covered lives assessment and then decide, yeah, but this is also a service, and there's also an extra service I want to make available to my employees. But the fact that they're paying 7 cents PM doesn't impair in any way their ability to design their benefit plan.
Right.
So I think that's one of those safe harbor tests, if you will, hopefully.
Yeah, and that's the debate with the PBM stuff, right?
Mhm.
What gets to a central matter of plan administration? And what is a central matter of plan administration? Participant eligibility and benefit design. So that's another way to think of it. And at least that's the way I still think of it. Maybe I'm locked in an old school way of thinking about ERISA preemption, but that central matter of plan administration was referenced in the Rutledge case.
I think, Liz, I think we should probably go on to our conversation about next steps.
Yeah,
Thank you, everybody there.
Yeah, plenty of thanks. I'll be thanking everybody here in a minute to finish next steps, but yes, thank you, Roger.
sure. And we just want to say, that, I mean, this was the beginning of a discussion, and I hope really got people thinking about, you know, ways to do this universal system, and, you know, move around ERISA. I think we've been, you know, thinking about that, and lots of great ideas and thoughts, I think, starting to emerge. Our next steps are that Pam, your chair, our liaison, is going to take this back to the commission, summarize the conversation that we've had, and some of the questions that emerged, and then hear from the commission about their additional questions that they might have based on this foundation that was provided today through Dr. Shakar and Jane. In September, we'll come back, really taking what we heard today and hopefully having a little bit more clarity about potential ideas and recommendations based on what we heard today. And then in October, the commission will once again hear from Pam, and then vote on what we're going to be doing, vote on the final version of the 2023 legislative report, which will include the Medicare recommendations at this point. It's not likely that they're going to include this conversation at that point, just because of timing and drafting, but that's on schedule for October. So I don't know if there are any final questions or comments, things that folks want to make sure get back to the commission. Roger.
Yeah, I'm getting a little ahead of ourselves, and I don't mean to do this, but I have reason to believe that for our September meeting, there will be some additional documents. I'm thinking of the study by Brown and McCleskey that I think will help us members think about options.
Yes.
To be able to, to enrich our September discussion on potential options to advise, the commission on.
Absolutely. And we want to acknowledge all of you for identifying our speakers for today, because this conversation happened because of the suggestions you've all made. So we would encourage you, if you have other ideas about how to enhance this conversation for September, please send them to Pam and Angela. I think, Jane and Dr. Shakar really helped me, I will say, and hopefully others, to understand that this question of tolerance around what would the self-insured plans tolerate, and some of the examples that we've seen be successful here in Washington, I think will help the commission to understand a little bit more about potential options as well. So encourage you to keep bringing forward speakers and examples that you know about, and bring your expertise to this group, because it's the only way we're going to be able to kind of come up with some options to put in front of the commission.
Thanks, Liz. And I just want to note too, Roger, that federalism article by McCuskey and Fusey-Brown, Erin Fusey-Brown will be at our September meeting, helping guide that discussion. And she was the author or co-author of that article. So, and we'll send that. It's quite lengthy. It's about 78 pages, but it's really clearly beautifully written. And I agree, Roger, I think that's going to be great for our September discussion. So we'll definitely be sending that out well in advance of the September meeting.
Thank you.
It's your summer reading assignment. I see David's hand up again.
Yeah, Liz, if our colleagues in California or Oregon have wrestled through these same questions and there's any, if there are any documents of their deliberations and conclusions that they came to, I think that would be helpful as well.
Angela,
You got it.
did anything else that you're pulling together?
Yeah, well, we sent the the Oregon memo from Aaron and Elizabeth in today's materials. They also did some work in California, which we'll be able to include certainly for the next meeting. We'll get you all set up.
Will it be a test too?
It's going to be an essay test, not Scantron. So,
Oh, good.
so you better study. Okay, I'm going to hand it back to Pam.
Yeah, thanks. I think the essay test, Roger, is that we have to be able to have a conversation at our next meeting where we'll be able to kind of think about what kind of guidance we want to take back. So I can't think of a more challenging essay exam than that one. So I want to really express my appreciation to Jane and Carmel because I found the presentations really enlightening and helpful and really helpful in getting our thinking going on these kind of different ways of looking at these issues from, very legal and then kind of bringing it into this pragmatic, looking at what have employers and carriers and the public sector done here in our own state to move some of these issues forward and what questions does that raise. I also want to add my thanks to committee members who helped think of names of speakers and really appreciate you kind of coming to help Angela think that through so that we have, these kind of discussions, so we're able to have these discussions to set up kind of our further conversations about how we might offer advice to the commission. And of course, I want to thank all the committee members. I want to remember to thank the staff who do a lot of work in front of the scenes, behind the scenes with us, answering our questions, wrestling a lot of different things to make this all work out as well as it does. So, thanks again to everyone for a really good meeting. Our next meeting is going to be September 14th, and we'll be digging into ERISA. As you heard from Angela, get ready for that to land in your email. And again, I want to reiterate, if there are ideas or thoughts about what else we should be digging in, especially as you kind of noodle on some of this conversation that we had today, please reach out to Angela or myself, and we'd be happy to kind of figure out how to collaborate with you on that. Thanks again for everyone's participation. And I think this is actually a first that we're actually done 2 minutes early. So everyone, thanks again.